Hello and welcome. I'm Bob Cusack, Editor-in-Chief of The Hill. Thank you for joining us for our program today, Chronic Kidney Disease, Forging Patient-Centered Solutions. 1 in 3 American adults is at risk for developing chronic kidney disease during their lifetime, a devastating condition currently affecting an estimated 37 million Americans. 15% of adults are estimated to have CKD, but 90% do not know they have it. Racial and ethnic minority populations in the U.S. shoulder a disproportionate burden of both CKD risk and negative outcomes. Today we are speaking with policymakers, patient advocates, and equity experts on treating this disease and eliminating disparities. But before we get underway, a few housekeeping notes. You can tweet us at @TheHillEvents using the hashtag #TheHillCKD. We are broadcasting live and will be taking your questions throughout the program. My first guest today is Tom Duvall, the Director of the Division of Special Populations and Projects at the CMS Innovation Center, where he oversees models designed to improve care for beneficiaries with chronic kidney disease. Welcome, Tom.
Thank you.
Tell us a little bit about, and I used to cover CMS a lifetime ago when it was actually a different agency name back then, HCFA. What is the CMS Innovation Center, for those who don't know, and your role in it?
Sure. So the CMS Innovation Center was set up by the Affordable Care Act in 2010. And our job is to test out new ways of paying for care within the Medicare program and Medicaid as well, with the goal of really improving the cost and quality of care for beneficiaries.
And what barriers do patients face with chronic kidney disease, and how is CMS attacking them?
Sure. So there's a few different ones. The biggest one is getting diagnosed in the first place. There's an unfortunately large percentage of folks who never know that they have chronic kidney disease and then wake up in the hospital one day and need to go on dialysis. Another big one is I think just the need for more resources to be put into the efforts against chronic kidney disease. So as a result, at CMMI here, we're currently operating 2 different payment models that both impact the efforts to combat chronic kidney disease. Our big one is the Kidney Care Choices model, which focuses on coordinated care for beneficiaries with CKD and gives nephrologists additional payments for managing care, as well as some additional ways to bill the kidney disease education benefit with the goal of really increasing education and enhancing the care that beneficiaries can receive.
And I was going to raise that model that you just mentioned, the Kidney Care Choice model. What was the impetus for starting this, and how has it done so far?
Sure. So we ran a previous model, the Comprehensive ESRD Care Model, from 2015 to 2021. And that was just beneficiaries with ESRD who were already on dialysis. So one of the big lessons we got from that, and we had some pretty good results on that, about a 3% reduction in hospitalizations. But we saw the need to kind of go upstream to include beneficiaries with chronic kidney disease, as well as beneficiaries in the transplant process there. So I think the real goal was to kind of learn and build on the efforts that we had tested out in that model. So the KCC model only started January 1st, 2022. So we unfortunately don't have any results yet. We do have 81 participants currently in the model. With approximately 130,000 beneficiaries, and we're adding to that number then for next year. So I think we're pretty pleased by the response from the community and then all the nephrologists and other healthcare providers that have stepped up to be a part of the model and really help to coordinate care. So unfortunately, no results yet, and we're not really going to have results probably till next year that we'll be able to share with the results from 2022. But I think we're pleased by the interest and sort of outpouring of support and investment to participate in the model.
Yeah, you mentioned getting tested is so important. Just from 30,000 feet and people watching this, how do they know? Who do they go to make sure that they know whether they have this or not?
Yeah, I think the best way is working through the primary care provider, making sure that they do sort of the full set of labs, and getting your GFR is the most important measurement, glomerular filtration rate, which is generally part of the panel of tests. Then if a person is at risk of CKD or sort of test positive for CKD there with a reduced GFR, then to get that referral to the nephrologist, and the nephrologist can manage the care from there. I think the real key is identifying the patients who have a lower GFR getting that necessary referral to the nephrologist, and then sort of having the nephrologist really take on the care to ensure a later and smoother transition to dialysis if necessary.
As far as CMS and health disparities and making sure that everyone is getting the care they need, not just the well-off, what is CMS doing in that regards?
Sure. I know in this area, this is obviously a huge one, given the population of who gets CKD and who gets ESRD in the first place. I think with this model, we're really looking at the increased resources and effort that are going into it. We think is going to make a huge impact in the lives of these beneficiaries. And we have within the KCC model sort of significant waivers, both to enable providing and dealing with a lot of the social determinants of health that currently prevent barriers to accessing care, such as transportation, as well as I think increased flexibility to be able to bill additional services to really be able to help out folks who may not have the resources to access care on their own.
We do have an audience question from Christina Battarochu, if I'm saying that right, to play for you. Christina?
Good morning. I'm Christina Battaraco, a research scientist with Avalier Health, also a registered dietitian. I'm wondering how you think providers and care models can better connect patients with nutrition-related interventions to both reduce risk of chronic kidney disease as well as improve and optimize their health outcomes.
Yeah, I think nutrition's a big area. Part of what we do at CMMI and kind of our general theory is that if we set the incentives correctly, that providers will effectively respond to the incentives and figure out the best ways to manage care. And there's lots of different areas to attack and focus on. Diet is an important one. That's in part why in the CEC model, we included a special waiver to allow dialysis facilities to distribute nutritional supplements to beneficiaries. And in the KCC models here, we have some broader waivers around providing in-kind services like nutritional services. I think dietitians play a very important role in the process. And we also have our waiver to allow dietitians to be able to deliver kidney disease education services, which we think that they're eminently qualified to do because they're such an important part of the care team here.
As far as the role of innovation, how does that fit in to make sure that things, new treatments are being okayed by the government, but they're safe, and also payment policy, because obviously the CMS is a leading agency on reimbursement?
Yeah, I think from the CMMI perspective, our thought is that if we set the incentives correctly, that people will respond to them with whatever appropriate treatments there are. And if there are new innovations that come on that sort of can create more cost-effective treatment, then we sort of hope that folks will pick those up and begin to really deliver them for beneficiaries. I think the real hope with these models is it's moving away from some of the fee-for-service mindset of I need to build this and sort of look for an increase in billing revenue, and really try to move to a total patient mindset where we're trying to take care of all of the needs of the patient and figure out what can best sort of help out their overall quality of life and reduce overall spending, which we think definitely opens the door for a lot of new kinds of treatments that folks may not have been as interested in before.
How did you come up with the kidney care choice model as far as like talking to consumer groups and others, just overall stakeholders? What role did they play maybe then and now?
Sure. Yeah, I think we worked a lot with sort of building off of our own lessons from the CEC model, which we had run, but also trying to learn from everybody in the field, dialysis facilities, nephrology groups, patient groups of all variety, really trying to take in information from as many stakeholders as we could to try to figure out where we could best set up the best model to really improve care for folks. It really was a broad variety of different people and really just trying to build off of our experience in running the CEC model, as well as some of the larger CMS experience in running other ACO models.
As far as, when you're diagnosed with something like this, I'm sure it's a tough day. And there's so much, the internet is a great thing, but it also can be scary. As far as consumers are concerned, and there's a lot of information out there, what are the best resources for them to go to, whether that's government or other resources? I mean, it may not have to be online, but obviously that's where people are going first nowadays.
Yeah, I think we definitely encourage folks to reach out to groups. Like I know the National Kidney Foundation puts out a lot of great patient-focused materials there. I think what part of what we're really pushing with our models is to really kind of bolster the nephrologist in this effort, recognizing the nephrologist as the relevant kind of quarterback here, coordinating all of the care, and to really serve as the primary care provider for this patient. And I think what our goal is that one of the positive effects of these models is to really increase the capacity of nephrologists, I think to go beyond what they were able to do before and go beyond just a fee-for-service billing mindset to kind of a total patient care needs perspective. So I think we're really hoping that we'll bolster the ability of nephrologists to be able to provide those resources there.
And without a doubt, the future of healthcare is moving away from fee-for-service and other type of models that you've outlined here. We've run out of time, but Tom Duval, Director of the Division of Special Populations and Projects at the CMS Innovation Center, thanks so much for joining us today.
Thanks.
My next guest is the ranking member of the Energy and Commerce Health Subcommittee, which is a very important committee and subcommittee. He is also the chair of the Healthy Future Task Force. Welcome, Congressman Brett Guthrie.
Thank you for having me today.
Oh, yeah. Okay. Well, let's see. How did you first get involved in dealing with chronic kidney disease? What got you interested in it? Obviously, you're on the Health Subcommittee, a leader there.
Right.
But what was your basically finding
Well,
out?
it's
Wow,
a
this is a
story
problem.
as a father. So my son, when he was 8 years old, had some fevers and so forth. So we kept taking him to the doctor. They finally figured out it was an infection, and turned out that he had issues with his kidneys. We thought he was going to, at 8 years old, we thought our son was going to lose his kidneys. We were going to be in dialysis and maybe transplant. My wife and I were looking at each other. Maybe we're going to be doing a transplant. I got the one, my wife and I and my son got the diagnosis that every parent wants to hear in that situation. If you go into Children's Hospital saying, we can fix this. And so he's now 27. He has one full kidney and one kidney that's, matter of fact, the doctor even said if he lost his good kidney, the other kidney may have enough volume he wouldn't have to have a transplant or dialysis. So Congress is a snapshot of America. It truly is. I know a lot of people, when you watch TV, you don't think that, but there are people that have every different life experience, particularly the House. And so people take up issues because they know them. And this is one that I was there. He's now 27 years old, as I said, almost 20 years later, and everything is well. But I've been there and seen it and worried about it. And so I walked in some people's shoes. Fortunately, we had a better outcome than others have had. But that's what got me interested in kidney care. So anything that deals with kidney care, dialysis, remote dialysis, where people can take it home, is something that I follow very closely because we were there.
Sure. No, and that's, as you say, that's why a lot of members get involved, is either a personal experience or family experience, and that must have been so scary. Looking at it, that was a while back, and it's great your son's doing well. What has changed in that time? I imagine a lot. I mean, you had an upfront view of it from the consumer patient perspective. Where are we now, kind of big picture, and where do we need to go?
Well, I think what's happening now, if you look, because we didn't go through dialysis and so forth with them, but being interested in it, I've followed it. And I think now we have take-home dialysis, where I have another good friend of mine who just went on dialysis, an older, different story than mine. He's older, he's probably in his late 70s, who just started dialysis. And he lives about 26 miles from where I live in Bowling Green, so they drive 3 days a week. They're driving in, so you talk about what, $5 a gallon of gas affects them moving forward. And so I think innovation that people can now do some in situations where they can take home dialysis, that brings in telehealth, how we have to deal with telehealth moving forward, and after the emergency pandemic has been lifted, to make sure that we don't go back to the way that it was before. We have a plan in place to move forward. And so I think it's improved. Like I said, we avoided it. We thought we were going to have it, but we didn't. So we avoided the kidney failure or chronic kidney disease. So we didn't really experience it to say the difference between now and then. But I think what we're seeing is take-home dialysis from home, I guess I should say. And we need to have those services so people don't have to travel in every day or every 3 days if they don't have to do that. But make sure that the providers who provide that services are reimbursed for what they do, given the situation.
You mentioned telehealth, which is something obviously has naturally exploded since the pandemic. My 3 kids and wife and I have used telehealth services. We never did before. I know it existed, but now it's expanded. What can Congress do, and what should Congress do to keep that intact? Because obviously it's something that's very important when people, for a variety of reasons, whether it's pandemic or other reasons, they can't leave the house, but they need to talk to a doctor.
Well, we need to sit down together and work on it together. And currently what is happening is just the telehealth is just being extended as it is without looking. There are a lot of questions to ask we have to have answers for. One, typically if people are, now I live in Bowling Green, Kentucky, which I'm an hour from Nashville. So my son actually had his surgery at Vanderbilt. And so you do cross state lines in the old school of healthcare, but physicians don't travel as much. So you've got state licensure issues, you've got access issues, you've got reimbursement issues. How do you reimburse people moving forward? And how do you prevent, people from just creating phone centers and billing the system moving forward? Because unfortunately, there's always people that take advantage of that. So those are the things that we need to look for. We really haven't gotten there. There's other things that have been, I guess the majority has been focused on, which I know there are a lot of things going on. We're trying to do the drug user fees and trying to move those things forward. But as you talked about me being leader of the Healthy Futures Task Force, that's set up in case we are the majority. What are the issues that we're going to pursue as we move forward? And what we tell everybody in the Republican conference as we get together, if you remember before we had the Affordable Care Act and repeal and replace, and that was kind of drove us in 2017 after President Trump came into office. But the only things we're going to be able to do and accomplish are things that President Biden will sign because he's going to be president in 23, 24. And so telehealth is one of those things. We can sit down in a bipartisan way. So our hope and objective is we're going to have policies ready to go if we take the majority. And it's going to have to be bipartisan because you got to get it through the Senate. And there's not really any estimate you're going to have 60 votes in the Senate. We certainly got to get the president to sign it. So those are issues that we're going to work on. We're going to be, we want to have victories. We want the American people to see that government can function, it can work, we can work together. And the necessity of a split government, if we take the majority, which it will be, we'll have to work together. And so hopefully we can prove to the people that can happen. And healthcare is a number one issue because most of this issues with healthcare, sometimes the way who pays for it and how it's paid for is different. But the actual treatments and so forth is a bipartisan issue.
You mentioned you're co-chair of the Healthy Future Task Force. How did this task force come about? What's on the task force agenda?
Well, the objective is we have several task forces in the Republican conference, Leader McCarthy put together task forces. Be ready. If we take the majority, we want to be ready from day one with what our agenda will be if we move forward. And so there are several different task forces dealing with big tech, dealing with judiciary, mine with banking and finance. Specifically, ours obviously is healthcare. And so as we sit down and work through this, we work through, as I just said, the prism that everything that we're going to be able to accomplish in the next 2 years, if we're going to get bills signed into law, are going to have to something that we can work together on. And I know a lot of people are watching this that if you watch cable news, you don't think Congress works together a lot, but there are a lot of things in line that can be moved forward. There's HR 19, which is a bipartisan bill for pharmaceutical reform, for pharmaceutical pricing, bringing biosimilars into the mix big quicker, have a lot of other things that we can move forward in order to get prescription drug pricing down. Now, there's another bill out there that's in the Build Back Better that wasn't bipartisan because it had some drug pricing issues that we felt like will lead to price setting, leads to shortages that we've seen in the sort of in kind of indirectly in the baby formula issues because of driving down margins and driving people out of business. So we got to be careful of that. Everybody wants cheaper prices, but we also have to make sure we ensure we have innovation and we have people producing the products that we need.
And as you mentioned, Congress is not viewed as, we're in polarizing times, but there are bipartisan pieces of legislation that are working its way through. One of them you've been involved in is the FDA Act that recently passed the House. What's its prospects in the Senate? Could this get done this election year? Which is, as you know, it's tough to legislate.
Very good question today, because today I think the Senate's having their hearing on what their version of the bill. We passed the bill. I think it passed 300, and I know there were 28 no votes, so maybe there were 390 yes votes, I believe. So it was extremely it was well done. It was people working together, coming up with compromise and trying to move forward. So what this does is I know most of your audience here are technical and follow this, but if you don't, it's the user fees that pharmaceutical companies, medical device companies pay to the FDA to get their projects reviewed and to make sure that FDA is properly staffed to move forward. And this has been very important since we put this in place. And America is the leader, and I think in the 1990s for FDA user fees for pharmaceuticals in the early 2000s. Matter of fact, Anna Eshoo, who's the chair of the subcommittee, was the mother, I guess, of that bill. And so it's brought innovation, and America's leading in innovation in healthcare, and it allows innovation to get put into the marketplace quicker. Accelerated approvals. I've got a provision in there called Information Exchange Act, that Pharmaceutical Information Exchange Act, because what we're seeing now is you'll get a pharmaceutical approved, and then it takes a year to get on a formulary for a healthcare system or for a health insurance. And so people will say, well, I've heard about this blockbuster migraine drug or other types of moving forward, but I can't get it because my insurance won't cover it. And so what we're trying to do is bring that lag time down. Like I said, all this is bipartisan. Sometimes it's just in the details that we have to negotiate. So the perspective, I think the bill will get done by the 1st of August before we break in August. The House has already passed it. Hopefully the Senate will pass something before the 4th of July break, and that will give us the month of July to come up with a difference. But I would really venture to say that by the 1st of August, the president will sign a FDA Act.
Oh, that's impressive. As far as the Republican agenda, as you know, Congressman, the chances of the House flipping are pretty good right now for Republicans. We've been reporting on Kevin McCarthy and his leadership team putting together an agenda for what would happen should you take over the lower chamber. I imagine healthcare is a big part of that. When are we going to see that new contract with America?
Well, good. So the overall theme that I believe that we should have is America needs to get back where it works again, because you can't get baby formula. You line it in $5 gas. So a lot of things just aren't working. And I think people are frustrated. I know when I'm home in my district moving forward. So we want to put together a health system that works, where people can get the services they need. They can afford what they are moving forward. And so there are pieces that are already rolling out. And so by August, we should have because we take the August recess, as they call it. We go home and work. It's not like recess from schools. That word, I think, shouldn't be used by us here. I shouldn't have said that, I guess, because we actually, in August, will be going home and presenting our findings in our agenda to the American people in our districts. And so you'll see a product. There's been one-pagers, I guess, and not the full report that have already rolled out of about 3 subcommittees. And so we're going to have those by the end of the July. And so we'll be out in August promoting what we want to see American healthcare to be. And again, a lot of it isn't going to be, I think it's major. And so, but it won't be what people will call major headline type of legislation. For instance, Medicare Part D reform, which is absolutely bipartisan. Medicare Part D is one of the few drug benefits that people have that does not have an out-of-pocket cap. And so we want to have out-of-pocket caps on Medicare Part D. That sounds like something small when you compare it to the Affordable Care Act or repeal and replace the Affordable Care Act. But Medicare Part D affects every American over the age 65. And a lot of people in kidney care with out-of-pocket expenses. That this would limit that. It doesn't. We still have to solve the problem of high-price pharmaceuticals because the government picks up the rest of the tab. But it would really relieve a lot of our seniors who are in the situations that we're talking about today, because at least they'll know once they reach their cap, whether it's agreed upon to be 2,000 or 3,000 or and smooth throughout the year, once they reach their cap, then they're no longer going to have to pay for it. That somebody else has to pay for it. The insurance plan pays for it, which is for Medicare Part D, a lot of it the government. So we still have a lot of work to do on pharmaceutical pricing, but it will take the stress off everybody in America over 65. That's a pretty big deal. I think we can do it.
Yeah, no, that's it. Part D's a big deal. I was there when they created it in 2003. It wasn't easy, but it got through after some arm twisting. Congressman Brett Guthrie, ranking member of the Energy and Commerce Health Subcommittee, thanks so much for joining us today.
Thank you so much for having me.
It's now time for the sponsor perspective portion of the program. Please welcome Kevin Bernier, Executive Director of Advocacy Relations for U.S. Pharmaceuticals at Bayer.
Thank you for the introduction and welcome. I'm grateful to all who are joining this important discussion today as we aim to elevate the challenges facing many patients living with chronic kidney disease in the U.S., including those patients with type 2 diabetes. 15% of U.S. adults have chronic kidney disease, also referred to as CKD, and more than half of U.S. adults aged 30 to 64 are expected to develop CKD during their lifetime, a condition currently affecting an estimated 37 million Americans. It is important to note that type 2 diabetes is a major cause of CKD. Approximately 40% of patients with type 2 diabetes have chronic kidney disease. CKD accounts for more than 20% of total Medicare spending. And more sobering, 9 out of 10 adults with CKD do not know they have the disease. Perhaps the most devastating fact about CKD is that without treatment, the disease can progress from living with reduced kidney function to end-stage kidney disease or total kidney failure. Patients with end-stage kidney disease require dialysis or a kidney transplant to survive. Decades of underinvestment in kidney health screening, care, and treatment options have resulted in too few patients being diagnosed early and getting the treatment they need to slow their kidney disease progression, which may lead to dialysis. The U.S. Department of Health and Human Services is aware of this, which is why it is a goal of HHS to reduce the incidence of ESKD by 25% before 2030 through improved surveillance and adoption of interventions aimed to reduce the progression of CKD. However, adopting new interventions is slow while the challenges compound. And to really drive home this point, every 24 hours, 340 people begin dialysis treatment because of kidney failure. Once a patient is in dialysis, the 5-year survival rate in the US is only 35%. While these statistics alone are alarming, health disparities in chronic kidney disease are truly distressing. Data have shown that African Americans in the United States, Aboriginal groups in Canada and Australia, and Indo-Asians in the United Kingdom are affected disproportionately by chronic kidney disease. Further, the associations of socioeconomic status and risk of progressive CKD and eventual kidney failure have been well described, with persons of lower socioeconomic status bearing the greatest burden. While Black Americans make up approximately 13% of the US population, they comprise more than 30% of patients with end-stage kidney disease in the US. Health access problems faced largely by communities of color result in Black Americans experiencing a 3.5 times greater risk for progression to end-stage kidney disease as compared to white Americans. Moreover, Black Americans are more than 3 times as likely, and Hispanic or Latino Americans are 1.3 times more likely to have kidney failure compared to white Americans, which underscores the importance of ensuring timely, effective care among people of color. Data confirm that CKD is a massive and growing issue for the American health system. But while more and more patients are impacted by this terrible disease, access to screening tests and treatments remains woefully inadequate. A failure to perform timely screening tests often makes detection out of reach for many patients, exacerbating existing health disparities for those who already have less access to health care than white Americans. Furthermore, once a patient is diagnosed with CKD, they often face complicated and burdensome processes to access the medications they need to manage their disease. Recent estimates show that Medicare alone spends more than $120 billion annually on kidney disease. Both Medicare and commercial health plans generally see a cost increase as CKD progresses to later stages. While there is no cure for CKD short of a kidney transplant, there are treatment options to reduce the risk of kidney disease progression. But advancements in diagnostic testing and CKD treatment cannot begin to change the tide of the burden of kidney disease in America if patients cannot access them. We are hoping today's dialogue becomes a call to action. Our health system can and must do more to reduce the risk of CKD progression and bridge health equity divides in kidney disease management. There are essential benefits and services that need to be accessible to all Americans equally. we support the Department of Health and Human Services Healthy People 2030 goal to reduce the burden of chronic kidney disease. We believe one strategy necessary to achieve that is to ensure patients have unrestricted access to medications shown to improve kidney health and slow the progression of CKD with little to no copays. We also look to policymakers to ensure that physicians and patients can select the most appropriate therapy without unnecessary barriers. Reducing health disparities in CKD must be our top priority. Preserving kidney function can also preserve health system resources and improve lives. I want to thank the many advocates who for years have been fighting for better access. Their efforts have led to improved comprehensive kidney health evaluation rates and address gaps in care for patients with diabetes and CKD. In closing, it is up to all of us to collectively ensure that patients are able to access the treatment options they deserve. Thank you.
Thanks again to Kevin Bernier, Executive Director of Advocacy Relations for U.S. Pharmaceuticals at Bayer. Now it's time for our panel of experts featuring patient and physician voices to further discuss better diagnosis and treatment of chronic kidney disease. Please welcome, we've got some great panelists here, Dr. Susan Quagan, the President of the American Society of Nephrology, which represents more than 21,000 kidney health professionals, Dr. Elena Rios, CEO and President of the National Hispanic Medical Association, representing 50,000 Hispanic physicians in the United States, Kevin Lonino, CEO of the National Kidney Foundation and a kidney transplant recipient. We'll get more into that. As also Richard Knight, President of the American Association of Kidney Patients, and he is also a kidney transplant recipient. So we want to hear those stories. Thank you all for joining me. I'm going to start with Susan. Your association has released the United for Kidney Health initiative. Can you tell us a little bit about that?
Sure. Well, thank you very much, and really great to be here and focused on chronic kidney disease. So the United for Kidney Health is a strategic plan that sets the priorities of our society, and it's focused on 4 pillars. One is to intervene earlier, and you've heard a lot about that already today, the importance of diagnosing kidney disease earlier, of transforming transplant, accelerating innovation and increasing patient choice, and achieving equity and eliminating disparities. And I think you've heard that message loud and clear. If we're going to make any impact on this public health crisis in the United States, we really must focus on all of those pillars.
Elena, let me go to you. What about the barriers that are facing the Hispanic community? Has there been progress in that area, and what more needs to be done?
Well, I think one of the biggest barriers, of course, is that the Hispanic community still remain about a third without health insurance across the board. But I have to say, with Medicare and Medicare Advantage, there are a lot more Hispanics. The trend is upward in terms of applying for Medicare, and I think because the elderly do understand the importance of their health. But when it comes to families getting information about high blood pressure and diabetes, which is rampant in the Hispanic community, healthy lifestyles, nutrition, physical activity, all those educational campaigns that are needed are not there in our communities. And I think because we don't have insurance, our country thinks that, well, if you go to the doctor, you'll get information on how to live a healthy lifestyle. But in reality, and I think we found this out with COVID-19 and the pandemic, we really need to put information into our public health infrastructure and in the communities where people live and work and play, which is what Healthy People is all about, right? To have more health information about getting your high blood pressure checked, getting blood pressure checked, getting your sugar checked, so that we can start finding kidney disease earlier. And I think that's one of the biggest barriers, just the information that's not out there in our communities.
Just a quick follow-up on that. What is the effect of the last 2+ years with COVID? Because a lot of people have skipped those preventative steps.
Right. I agree. A lot of people have not gone to, doctors' offices and dentist offices and hospitals all had to close,
Right.
except for the COVID patients. So yes, a lot of people lost their connection with their healthcare providers. I think the other problem with the dialysis centers having more people sick with COVID and having to isolate and not go into the dialysis centers, or dialysis center staff being sick and having to decrease the ability to provide services. So yes, there's been a lot of barriers with the COVID pandemic too, for our chronic kidney disease patients.
Richard, let's hear your personal story of kidney disease and getting a transplant. Can you tell our viewers kind of what that process was like?
Certainly. First of all, I want to say thank you for the invitation to participate in the event today. It's appropriately entitled Kidney Disease Forging Patient-Centered Solution. With respect to my personal story, I've been a CKD patient since 1996, when I was first told that I had protein in my urine, which is clearly a sign of impending kidney failure, which I did not know at the time. Fast forward several years later, I went on dialysis in 2004. Stayed there for a couple of years and was fortunate to be able to get a transplant. And I'm 15 plus years out on my transplant. But I want to emphasize this. My story is not dissimilar to many other patients. And what was discussed by Kevin Bernier in the beginning was something that I suffered from, which was not having the opportunity to have the progression of the disease slowed. When I found out in 1996 that I had chronic kidney disease, and I wasn't even diagnosed with it. I later understood that that's what it was, but it took me 8 years before I went on dialysis. That could have been slowed even further. And so I do want to emphasize, because as president of AAKP, and I represent patients, and that's really what we're about. And our whole organizing principle is about the kidney patient consumer care choice. And I can't get away from that, because we're intelligent consumers. We're like everyone else. We want treatments. And what was discussed earlier, access or inaccess to treatments, is something that we really have to focus on. So I'm glad to be able to talk here today. And one last thing I want to emphasize, because I didn't notice, and I think it's important to share it with people. The whole notion of patient-centered solutions really started 50 years ago, as I found out, by patient advocates. A patient advocate from our organization, 1973, led to bipartisan United States Congress, and then President Nixon signing into what we have today, the end-stage renal disease program. That remains the only disease-specific entitlement program in America. So I just want to say that it's important for us to understand our history and remember the patient-centered focus of that. And I wish I had known that sooner, and I might have been better off. But that's why we're here today, to educate folks and to continue to talk about solutions.
Absolutely. Kevin, please tell us your transplant story.
Oh, hi. My name's Kevin Lunge. My transplant story is not too dissimilar, except I had a good outcome. I went into a primary care physician with headaches that wouldn't go away. I was 39 years old. My blood pressure was off the charts, like 165 over 130. And the primary care physician noticed that I had a kidney disease in my family history and referred me to a nephrologist. And from there, I had a biopsy and found out I had FSGS, or a genetic kidney disease. What I didn't know until I came to the National Kidney Foundation and became a volunteer and now on staff is that this is such an unusual situation that I'm the exception. As someone mentioned earlier, 90% of the people in the country that have kidney disease don't know it. So there's 37 million people with kidney disease in this country estimated, and 90% have yet to be diagnosed. As Tom mentioned early on, it's primary care's burden to really pick this up because they're the ones dealing with the population. But there's been in the past, there's been a lot of issues and barriers to picking up kidney disease in primary care. And what we're trying to do as an organization and as a community and people on this call is to really get primary care empowered to do a better job to picking up those undiagnosed and getting those folks into some sort of treatment program that can delay kidney failure or even postpone it or even prevent it.
Kevin, your association has a consumer campaign that's called "Are You the 33%?" Tell us about that and how people can utilize that.
Well, it's a great campaign. Thank you for asking about it. It's a campaign where we're trying to let people, particularly communities of color, Hispanic, or folks that were Spanish or English is not their first language, understand that they could be at risk for kidney disease, understand what those risk factors are, diabetes, hypertension, family history, obesity, other things. See themselves in the quiz, take the quiz, find out where their situation is. And then if it looks like that they might be at high risk for kidney disease, we give that patient or that individual materials on how to have a productive and thoughtful conversation with their physician. If they don't have a primary care physician, we help them find one by reaching out to community health centers. And then we do the follow-up with that individual to help them make sure they have the patient education materials and the resources they need to really become an intelligent and thoughtful patient and someone that can really drive and take control of their kidney health as well as their overall health.
I'm going to go down the line, starting with you, Susan, and if you can give me about a minute or 90 seconds, and I know that's a short amount of time based upon this question, but based upon your experience, all of you have been in this field for years. Susan, what can Congress and the administration do that they're not doing? And it could also include things that are going well.
Okay, yeah, that is a loaded question. I think the foundation has been well laid earlier in the program that we have an incredible crisis in this country with 37 million Americans living with kidney disease, 90% not knowing it, 1 in 3 at risk. We currently have no recommendations from the USPSTF for screening. That's a US Preventative and Screening Task Force on kidney disease. The last time they looked at it was in 2012. And at that point, they said there was no evidence that screening for kidney disease, even at risk populations, was of benefit. Of course, we know that it's changed, and I'm incredibly excited. You're right, I've been in this field a long time. I think we are at a point in nephrology and kidney medicine where we have incredible, powerful new therapies that can slow progression of disease, just as Mr. Knight was talking about earlier on. I mean, drugs that are so powerful that it's sort of shout from the rooftop for the nephrologists in the field that can slow progression onto dialysis for the average patient of 15 years, and back of the envelope calculations could save 100,000 lives in the US alone in just 2 years and prevent 250,000 people going on to dialysis or losing a large portion of their kidney function. So the challenge, we know the data, the challenge is implementing this and getting these therapies to the patients who need them, to all patients who need them. So that requires a huge amount of effort, and I'm delighted, we have partnerships with the National Kidney Foundation, American Association of Kidney Patients. I mean, together it has to be the professionals as well as the patients stepping up and advocating for this. So I think Congress can do a lot of things. When we have champions in Congress, amazing things happen. We just saw that Immunosuppressive Drug Act, was passed because of champions, but there's so much more that we need. We heard about telehealth. We need that to be passed. We need access and the pricing of these drugs so that they make it to all patients. So I'm sure I've taken more than 90 seconds. I think I could carry on for hours and hours, but I want to give my other co-panelists an opportunity.
Yes, no, that's totally fair, and you did a great job. Elena, about you, I know you mentioned the uninsured. Obviously, Congress is not with the makeup and the majorities right now. It's not like, but what else do you see that Congress can do? And obviously, this is a bipartisan event. We interviewed a Republican, Brett Guthrie, going to be interviewing Congressman Payne. What do you think that can be done? And obviously, we're in divided government because of the filibuster. So Republicans have to go along with something in order to get it done.
Well, I think given the pandemic and I'm going to say the new buzzword of essential workers, let me say in our society, which to me means a lot of minorities and poor people. But I think if essential workers could be the focus, and knowing that we're going to have continued pandemics, continued importance of healthcare services to keep those people who have to face the worst of the pandemic's impact, is to help them. And I think that it may be a new era for us. And I'll just say it's health equity in a way that does not just focus on one community or another, and looking at health equity programs that can continue to be increased. So we have health equity at CDC for public health and Medicare for our elderly. We have research at NIH and ARC, and all of these agencies all have offices of minority health and health equity, which I think is slowly being considered to be changed to all people in our country that need a little extra help. So I think that, the Surgeon General had a big meeting about hypertension a few years ago. There's no reason why the Surgeon General can have a big meeting about end-stage renal disease and talk about the health equity impact. And I think a lot of that has to do with education, like I mentioned before, that is a bipartisan, very bipartisan to educate our communities to have healthier lifestyles.
Richard, if you had a magical Washington, D.C. Capitol Hill wand, what would happen?
Well, that's a great question. And I want to say this, and I really want to get to the what I believe is to the heart of the matter, access to some of the innovations that are available. We live in a golden age right now. If you have to have CKD, now is the time to have it. Organizations, ourselves, ASN, Dr. Rios' organization, our allies up on Capitol Hill, we're forced to divert time from educating to really advocating. In terms of the magic wand, I think we need to remind the government leaders, health insurance executives, that having a patient-centered worldview should be a constant and not a variable. I just want to emphasize, because I was struck by the numbers that Kevin Bernier mentioned earlier in terms of access, what Dr. Quaggan mentioned in terms of slowing down the progression of the disease. The reality is that sometimes interference comes in the form of limiting formularies, HMO-style gatekeepers, and administrative burdens that patients and doctors have to overcome. So, the diabetic kidney disease, for example, one of the drugs, Corinna, that's been available. I've had patients call me, and we're just having a tremendous time knocking down the barriers by some of the gatekeepers. So a lot of people talk about inequity and disparity, but what's being done about it? I get a little bit frustrated, but we have to continue on. I'm going to say that for our friends and colleagues, join us. We have a patient voice and a patient choice campaign, similar to what NKF has, where we're educating, working with patients and allowing them the opportunity to vote. But I really want to give thanks to those who have helped us. Dr. Quaggan mentioned the possibility of slowing down the progression of chronic kidney disease. Well, I want to call out companies like Express Scripts, CVS, and Cigna Health, who have allowed patients to have access to the products such as Corinna that slows down the progression of chronic kidney disease. However, we have some actors, we hate to name names, but humanity that just ignore the patients. It's unfair, it's unfortunate. Our concerns need to be addressed. Patient-centeredness needs to be real. I am so fortunate to have and participate in discussions like this. But when I have the patients call me and look at what they're going through and they can't get access to something that clearly is available, innovation and research is mute if we can't get it out there to the patients. So I encourage my colleagues to do what we can, and thank you for the opportunity to share some of our concerns and talk about solutions.
Kevin, let me go to you quickly. I do want to get to a viewer question, but I know a lot of great ideas have already been mentioned, but what's on your wish list?
My wish list, I think, real quick, I think what Sue said around the U.S. Preventive Task Force is right on. I think since they made their last ruling in 2012, federal government's probably spent $800 billion on chronic kidney disease, where 60% of it's preventative. I think I couldn't agree more with what Richard said. Access is important. We did a focus group study with primary care 5 years ago, and one of the number one reasons they don't pick up kidney disease in primary care is because they don't have a therapeutic. At least that's what they said 5 years ago. Now they do have a therapeutic, and those drugs are not available to patients because of insurance, and that's a problem. Lastly, though, I think the biggest issue, or not the biggest issue, a key issue that government could do something about is NIH funding and CDC funding. In the last 5 years, the NIH funding has increased 35%, but for kidney disease or NIDDK, it's only increased 19%. So kidney disease is not even keeping up with the growth of NIH, and yet we've already talked about billions and billions of dollars that are spent every year on kidney disease. And then chronic, the CDC's got a surveillance, CKD surveillance program. They only spend $3.5 million a year on it. That's million. And that's certainly not enough to deal with the public health crisis and public health issue that is kidney disease. So more spending from the federal government on upstream understanding of the causes and progression of kidney disease.
Yeah, budgets and priorities are key. I do want to get to the audience question that came in from Emily Arson. Let's take a listen and then have maybe one of you dive in, whoever wants to take it.
Hello, my name is Emily Arson. I'm a senior health policy analyst at the United Hospital Fund. My question is, what efforts can be made to explicitly increase equitable access to kidney care, particularly given that the eGFR has historically included race as a variable, which inaccurately mutes kidney function in Black and Brown patients? Thank you.
Anyone want to grab that one?
Sure, maybe I'll jump in. So I think the question is an outstanding one, and I think it emphasizes the importance, again, of patient and healthcare provider partnerships. So community engagement is one if we're ever going to get equity and access in this country. In addition, the comment about the eGFR was an excellent one, and ASN and NKF launched a task force in 2020 recognizing that race is a social construct, not a biologic construct, and has no place in clinical algorithms. And the kidney estimating formula, which is just an estimating formula, used to include it. So the task force reported out with a new equation that is done millions of times in this country that removed race, with the potential, and NKF has taken the lead in implementing this across the country, which will now hopefully improve access and reduce sort of downplaying kidney dysfunction in patients who are of African or who are African American or Black in this country. So that was a big step, but clearly way more issues to go. And in addition, I think just following up on Kevin's point about the funding for research, one of the other recommendations that came out of the task force was we absolutely need more research, better ways to estimate kidney function, and couldn't emphasize enough that NIH funding needs to increase kidney disease and kidney health.
There you go. Anyone else want to weigh in on the question, whether it's funding or anything else, or any kind of closing statement? Because we're just running out of time, but I want to may not have gotten everything you want to say.
Well, I'd just like to add that I want to thank my colleagues for the work that they do in this area. And certainly the issue of inequities and disparities is something that weighs on the minds of all of us. We must do a better job, and I'm going to say that ASN, NKF, Dr. Rios, great partners, but we must include the patients. Patients must have a seat at the table with these policymakers, and we need to understand, we need to do more than just talk about patient-centered. We actually need to engage the patient.
Yep, that's some very good wisdom there. We have run out of time. Great discussion today. I want to thank our panelists, Dr. Susan Quagan, President of the American Society of Nephrology, Dr. Elena Rios, CEO and President of the National Hispanic Medical Association, Kevin Longino, CEO of the National Kidney Foundation, and Richard Knight, President of the American Association of Kidney Patients. Thank you for joining us. Thank you for telling your personal stories. Very powerful stuff.
Thank you.
My last guest today earned the National Kidney Foundation's 2021 Congressional Award for his work to fight kidney disease. Congressman Donald Payne represents the 10th District of New Jersey and is co-chair of the Men's Health Caucus. Welcome, Congressman.
Having me.
Well, just like some of our prior speakers, there are personal stories that deal with chronic kidney disease. Your issue is quite personal. Can you tell us your story?
Sure. I've suffered from diabetes probably the last 30 years, and in the last decade, it's really come to a point where it started impacting different processes in my body. I was losing my eyesight at one time, and I've fought numerous diabetic ulcers on my feet, trying to keep my limbs. And subsequently, we know that one of the impacts that diabetes has is definitely on the kidneys. And so about 2.5 years ago, might even be 3 now, gee, I can't keep up. But I was told that my kidneys were only working at 20% capacity, and that I need to go on dialysis. Being the kicking and screaming all the way to the doctor type that I am, I kind of put it off. And I had a very difficult bout with retaining fluid in my body because of the lack of renal function. And I subsequently was in the hospital for something else, and they kind of had me as a captive audience and put me on dialysis. And so, I've been on dialysis, I said, for the last 2.5 to 3 years. And going through that process.
Mm-hmm. Yeah, that's quite a reason to get involved in this. You are a leader on the Men's Health Caucus, and you mentioned, putting off doctor's appointments, which I certainly have done. I know a lot of other men have done that. What does the Men's Health Caucus do?
We try to explore the issues around men's health and making it something we bring to the forefront. And, with members of Congress, are human beings too. And so, we try to raise issues and awareness around men's health and issues that men suffer from, and try to make sure that, we have a healthy outlook on life, and nutrition and exercising, and everything to do to keep men in a healthy situation, state of mind, so they can do the things they need to do in order to serve their families and the community.
We have an audience question for you, Congressman, from Jennifer St. Clair Russell. Jennifer, please take it away.
Hi, I'm Jennifer St. Clair Russell. It's exciting to finally have medications that can protect the kidneys by slowing or even preventing disease progression, but many patients can't afford them even with health insurance. How can we help patients access these medications, especially without adding more paperwork for providers who often find themselves in prior authorization purgatory and endless appeal cycles?
Once again, it starts with awareness. And, we have many folks that subsequently don't have quality health care or don't have any health care. And we need to continue to recognize those issues, and on the level that the congressional level is identify that issue and make these wonderful drugs available to people wherever we meet them on the healthcare ladder. And I think that is really a way that what Congress should be doing is making sure that these drugs reach everyone that needs them. There shouldn't be a situation in this country where people are not afforded the opportunity to get these life-saving drugs because they can't afford them. We have an obligation in this country to support efforts to make sure that everyone is availed the opportunity to these drugs.
Congressman, do you see anything on the horizon that could help with CKD as far as what Congress can do maybe the rest of the year or going forward, or the administration on regulations? What is on kind of your wish list for coming up with solutions and getting patients the care they deserve?
Well, I mean, it's a continued battle, and sounding the clarion call, I'm very delighted to have received this great honor. But I just look at it basically doing my job, and something that I'm obligated to do. And so I will continue in that vein. And we need to just continue to support the efforts that we see, Kidney Foundation and other organizations are working towards, and to fill the gap where we can in order to support those efforts. I feel like I'm a supporter. These organizations are on the ground doing the great work, and I just feel an obligation from my bully pulpit to advocate for them in Congress and make sure that they get the resources they need and the opportunity to speak to change leaders in Congress that can be helpful in this fight.
I was talking to Congressman Brett Guthrie before, and he was making the point that, okay, we're in polarizing times, and there's a lot of partisan battles, especially on health care, notably the Affordable Care Act. But he says a lot of things can get done. Have you seen on combating kidney disease some bipartisanship, and do you talk to your Republican colleagues on some of these issues?
Absolutely. I mean, kidney disease is not a partisan issue. It crosses across the aisle and back. And so, we need to look at these things as human conditions and not make them political footballs. Everyone wants to have a healthy life. And, I look forward to trying to do everything I can to stem the tide of unnecessary needs for people to go through these very difficult situations and eventually, hopefully, operations. More screening is really the key. to making sure that we get to folks in time before, they succumb to kidney disease and then subsequently need a transplant. So, we'll continue to do the work we need to do, but I'm always engaging in my colleagues on the other side of the aisle in reference to these situations, because like I said, they are not partisan. They impact everyone in this country.
That's very true, Congressman. Not everything has to be a political football, and congratulations on your award, and thank you for joining us today.
Thank you for having me.
And that brings us to the end of our program today. Thanks again to Bayer for its support of today's conversations, and thank you all for watching. For those of you who missed any of these conversations this afternoon, we will have video up on our website, thehill.com, very shortly. I'm Bob Cusack. Thanks for joining us. Have a great day.